we go. Good morning. So as Peter said, I'm Eric DeJonge. I'm a geriatrician, primary care, work here in DC at MedStar Health at the Washington Hospital Center. And I'm going to talk about, you can put up the first slide actually. I'm going to talk about, first and foremost, a patient and kind of what is possible in the use of the model of home-based primary care. The patient is Miss Frances Humes. I met her in 2007, and our house call program cared for her for 9 years. She passed away in March of this year in 2016. But I'm going to tell a little bit of the story of her life that, as I knew it, and then Miss Butler, who's to my left, who is her daughter, will talk about her experience as her caregiver. Ms. Humes was 86, and she had severe rheumatoid arthritis. She was bedbound for all the years that I knew her. She had blood clots, she had pneumonia, she had heart failure at times. She had a hip fracture that she suffered at home. She had diabetes, hypertension, and a whole raft of chronic illnesses, but she was a radiant kind of person. Whenever we would visit her, she would have this kind of bright, positive, shining light and was more interested in the people coming into the house than worried about her own medical problems. So that's Ms. Frances Humes, and we're going to hear a lot more about her from her daughter. I'm going to go over, you can go to the next slide. I'm going to go over one kind of summary about what home-based primary care can do, what's possible with this model of care. Really, it serves the 5% of elders who have trouble getting to the doctor's office, people with severe chronic illness and disability. It's team-based, it's mobile, and it includes medical and social services. And there's two people in the room I want to recognize. One is Ruth Shea, who's sitting over here, who is next to Miss Butler, who is Miss Humes's longtime social worker, who made probably hundreds of house calls, caring for her and helping her stay at home. Ms. Humes was dual eligible, so she had Medicare and Medicaid, and Ruth kind of was able to tap all the resources to help her stay at home. And Gretchen Nordstrom to my left at the end, who's our chief social worker on our house call team, who coordinates all of our social services. But social services are a key part of the team. It's 24/7, so the patient and families can reach you 24/7. It's full coordination of everything the patient and family need until the end of life. Number two, it works for patients and families, and from what we can tell, it promotes both dignity and kind of time at home. If I had to pick one metric for this population, it would be what number of days of the year that they are able to be at home. And it provides peace of mind to the family caregivers. Number three, it has proven success, actually. There's now a growing large body of published literature, as well as some CMS demonstration kind of data that's now coming out about rigorous quality and cost savings. The fee-for-service world and in the VA have shown $4,000 to $5,000 of savings per person per year, while being the highest rated program in the VA. Independence at Home, which some of you may know about, is a CMS demonstration program that tests home-based primary care. It's now served over 10,000 beneficiaries in the last 4 years. And all sites have met 3 or more of the major quality metrics. Many of them have met all 6 quality metrics, and there's been $35 million in savings in the first 2 years of the demo, ranging from 10% per patient to 30% per patient in the successful programs. Fourth, if you have this kind of independence at home approach, this payment model of paying for results and better outcomes for patients and families, you can get shared savings that will then grow the workforce. To grow the workforce to care for all these folks, you have to have competitive salaries and compensation similar to, say, what a hospitalist would get or another specialist would get, so that you can bring people into the field. And you have to also be able to pay for mobile technology, things that aren't always reimbursed on a fee-for-service basis, but you can use the capital from the shared savings to grow these programs. And finally, it is extraordinarily rare bipartisan success. Independence at Home, which helps us care for folks in DC and at 15 sites around the country, was a demo in 2012. It has now been extended on a unanimous bipartisan vote last summer through 2017, October 1st. And there's a bill in the Senate right now, S3130, that would make it a national program serving all 50 states and DC, so that it could be available to all 2 million beneficiaries who need this kind of care. It's voluntary, it has better clinical service, the proven success, we estimate through analytics of all the data that it could save $10 to $15 billion over the next 10 years if it was expanded nationwide. So it pays for itself, it doesn't require extra resources, and it's really effective in all settings. This is being done in both urban, suburban, and rural settings. So I'm going to stop there because I wanted to give most of our time to Ms. Butler. I'm going to introduce Ms. Butler briefly. Her bio is in your kind of folders, and I encourage you to look at that. She is kind of an inspiration to me personally in terms of how I do my work. I met her in 2007. She cared for her mom full-time for 20 years. She just celebrated her 70th birthday this week. And so until she retired 20 years ago to care for her mom, she was a math teacher in the DC public schools. And I didn't know this till this morning, but I think one of my favorite stats from any bio, she got the perfect attendance award for 24 years in a row as a math teacher. And she cared for her mom, and she will talk about that experience for the last 20 years, and I knew her for the last 9. And just to bring a coda to Mrs. Hume, she passed away after a brief illness in March of 2016, but we've been keeping in touch with Ms. Butler since then. Ms. Butler?